So let's just go through a couple of examples. First, the left to right shunt lesions. These are ASDs, VSDs, and even some more complicated defects like AV septal defects, AV canal defects here, where you can see the four chambers of the heart, the big hole right here in the middle with a single common AV valve. And then the color really shows that there's no flow going across these holes in the heart. And so these patients will actually be very well in the delivery room and actually for weeks after birth because the shunting doesn't happen until the pulmonary resistance falls, which can take weeks. So these patients usually can go home and then be seen as an outpatient. Another diagnosis that falls into this category is a little bit more complicated, Truncus Arteriosus, where here you can see the normal four chambers, but in this picture here, a single artery that gives rise to the aorta and the pulmonary artery. And then down here, the single outlet, which is the truncus. This is actually a lesion that does depend on shunting. And again, stable in the delivery room and maybe even in the first week of life. So these are what we call our low risk or level 1 diagnoses. Tetralogy, most common cyanotic congenital heart disease. We all know 4 things. 3 of them are present in the fetus. First off, as we start to look, the 4-chamber view is normal. This is why sometimes obstetricians don't see this diagnosis in utero. But just by angling a little bit superior, you can start to see a big hole in the heart. And then a little bit further, this is the aorta that overrides the interventricular septum. And a little bit further superior, we can see the pulmonary outflow tract. And this here is the pulmonary valve, doesn't look normal, so there's pulmonary stenosis. We all know there are pink tents and blue tents. Pink means the oxygen level is okay and they can be repaired electively. Blue is a ductal-dependent pulmonary blood flow lesion. So how can we decide whether this baby is low risk or medium risk, needing prostaglandin and transfer for an operation? There's several studies in the literature that tell us as fetal cardiologists what to look for. We can look at the size of the valve. But more importantly, actually, what we found is looking at the ductal flow pattern. In the fetus, the ductus should flow away from the lungs, so right to left. And if we see that reversed flow pattern, which is this little red jet, the left to right shunt into the pulmonary artery, this suggests that the pulmonary outflow is inadequate. So suddenly, just this little red jet tells me that this is a ductal-dependent lesion. We're going to need a neonatologist to put a line in and start some prostaglandin, and this baby's going to need surgery.